All right, I'm gonna go ahead and kick us off. Thank you all for joining. Really appreciate everyone's time and participation. We want to welcome you to the CDC Social Determinants of Health Public Health Use Case Workgroup for Chronic Disease Prevention. This is our fourth meeting. We are hosting a total of 8, so we're at that halfway point. Due to the large number of attendees, everyone has been muted. We are recording and you will receive all meeting materials within 2 business days via our Confluence site. You are encouraged to participate throughout the call. We really would love to hear from you live. If you would like to speak, you are welcome to raise your virtual hand using the reaction icon via Zoom. And you're also welcome to chat us in. You can use the chat function. Please send your chats to everyone so we don't miss them. And if you have any technical difficulties, you can contact our colleague Savannah. She's supporting us behind the scenes on today's call. Here's an overview of today's agenda. We'll start with some welcoming remarks, dive into the feedback received on the personas and story that was due on the 25th of May. Thank you all for submitting your input. It's really valuable and is helping us through this process. And then we'll segue into the review and discussion of use case 1 components. And we'll wrap up the call with some next steps and homework. For those who may be new to our call, if this is your first time joining, we welcome you to officially join the work group as a member. We're going to put in the link in the chat. You can register as a committed or other interested party. And if you are already a member, you have been added to our listserv. In case that you're not getting emails, you know you're registered, we encourage you to whitelist our email address, as you can see here. That is our workgroup email listserv through HL7. You can add that email to your contact so it can be filtered out of spam. If you have any questions, we welcome you to contact your IT personnel for support. In terms of any workgroup information or questions, you can contact myself, Savannah, and our CDC point of contact, Kyla. And I do see more people trickling in, so I'll give people just a second there to get settled. We'll love to see where you're joining us from. If you don't mind putting your entity organization name next to your name via Zoom, you can see myself as an example, Gabriela with EMI Advisors, that will be great. As you are familiar, we usually review our schedule. So today we are here on June 1st, and we have 4 meetings remaining until the end of July. To zoom in on today's objectives, we are going to review the workgroup input on personas and story and summarize and provide a summary of the changes that have been incorporated. We will also want to obtain your live feedback on use case 1 components. Those include actors, assumptions, pre and post conditions, and transaction diagram. And now I will hand over the virtual mic to Evelyn.
Thank you, Gabby. Good afternoon, everyone, and happy June 1st. So I'll start just with a general reminder, especially for new individuals that are joining us and may have not seen this in previous meetings, but we want to clarify today before we dive into the personas and the use case or the updated use cases that we are currently not defining. These are things that are out of scope, right? They've come up often. We're not defining data exchange standards or data elements for race, ethnicity, sex, primary language, disability, sexual orientation, or SOGI, and SDOH domains. So it's not because we don't want to, it's because these data elements are being identified in other projects. So in particular, HL7 has an Harmony project they've been working on SOGI, and of course, SDOH domains are tackled in the Gravity project. We're also not creating use cases that do not directly support the public health data activities listed in the scope statement of the charter. So again, refer there to the charter. We're also not, as a work group, providing any incentives for implementing the use cases or developing data sharing agreement associated policies to promote public health and healthcare provider data exchange. And lastly, we are not developing FIRE implementation guides. Again, this is not to say that our work will not inform a future FIRE, but within our scope of work with the remaining weeks, we are not developing a FIRE IG, but again, not to say that what comes out, the goal is that it can inform development of a future FIRE implementation guide. Next slide. So also want to recap again for those maybe not familiar with the Gravity project and its use cases, acknowledging that within the Gravity project, we developed the use cases in May and June of 2019. A lot has happened since then, but want to acknowledge that we were primarily focused on 3 use cases as listed here. And these are primarily focused data captured within a clinical setting, so as part of a patient encounter. So the first one is tied to the screening activities. The second is identifying, once a social need is identified by the individual and they want the health system to support them or intervene, there's activities related to that. That's use case 2. And then the last use case was the ability to gather and aggregate this individual level data for upstream uses. So this we say, for example, quality reporting, public health, population health, risk adjustment, and research. So again, we hope that our intent here is that this public health use case work and activities we will engage with you all will build on use case 3 and will focus on reusing the data, individual level data, for upstream in support of public health. Next slide. And what does that look like? This is just a visual of our 3 primary Gravity use cases. When we talk about data elements and their respective coded terminologies, data elements are defined based on activity. So this just shows our, LOINC for screening question answer pair, SNOMED for observations, ICD-10 for diagnosis. LOINC and SNOMED define the goals tied to person-centered planning. And then lastly, SNOMED are interventions, code the interventions. The aggregation of the data, we don't have specific data codes for it. These are really activities, but we know LOINC is primarily used for the outcomes and the measurement, but our work to date is not looking at the coded terminologies, it's just acknowledging that these are being defined through the Gravity project, and we will focus on building off the 3rd use case to create new use cases for public health purposes. Next slide. Okay, with that, I'm happy to hand over to Amy, but any questions before I move off? Okay, Amy.
All right. Next slide, please. So what I wanted to do was really just sort of, before we get into the conversation again a little bit, is to review sort of just the questions to keep in mind as, again, we're going through the feedback that we received from all of you related to the persona and the personas and the stories, and also consider these questions as we are going through the use case components that Sheetha will go through, and she'll come back to them. So again, the questions really are just keeping in mind, does all of this meet the needs of public health professionals? Is it a compelling reason to leverage SDOH data for public health purposes? Is there broad applicability? And does it really help us drive to a future state? Okay, next slide, please. So I just wanted to recap the different components in case anyone is new on the call today, but remember, just personas are really these fictional characters. They represent a person who's going to be using the service or the product, and it's really to give us all a feel and sort of make that the story relatable to different individuals in their particular roles. And these personas are also known as human actors in the use case, and we're going to get to that. As far as, then we have the story, and that describes how the personas are engaging with the service and the technology, and setting, really what we're trying to accomplish, the goal. And then the use cases are the actual narrative of the interactions between the systems and the personas in the system. So those are just the different components, just to refresh. Next slide, please. So again, just to remind everyone, we had a number of personas, and we did add, and I'll come back to this in a minute, we did add one new persona. It's Jessica, who's a case manager at a community-based organization. And we'll talk about the feedback that we got on other personas, and I'll come back to that in a minute. But we have Kevin, who's a care coordinator at the Community Health Center, and Jessica is new, a case manager at the CBO. We've got Claudia at a county health department, and Victor at a state health department, and Michaela at CDC. And then the story we really broke into 3 parts. Each part is going to equate to one of the 3 use cases. So part 1, just to refresh everyone's mind, refresh the story, is, in part 1, really Kevin from the Federally Qualified Health Center and Jessica from a community-based organization, they were attending a public health advisory committee meeting to the county health department, and they had mentioned at this meeting that they had noticed, both of them, increasing numbers of individuals with food insecurity. And Claudia at the county health department is working on a community health needs assessment. And she really wanted to leverage some of the social needs, social risk data from clinical and community providers to be able to look at this more broadly. And she learned that the regional HIE gets a lot of data from the clinical and some community providers or community-based organizations, and that it would be a good resource to potentially use to look at these issues. And the county health department gets into an agreement with the HIE to get this data and use it. So that's sort of the first story, the first part of the story, and that'll relate to use case 1. The second part really focuses on the state, and that's Victor. He is preparing a continuation application for the cooperative agreement that the state has with the CDC Division of Diabetes Translation. He also wants to look at decreasing food insecurity in areas of the state where diabetes is highest. And he also wants to see if there's diabetes prevention programs or education programs in those areas. He also is aware that the regional HIE has some data for that region from clinical and community providers, as well as thinking about getting potential social determinants of health data from other clinical and community providers that aren't part of the HIE, and Medicaid has some data. So he tries to work with all of these data sets to sort of help think about how to address food insecurity in areas with high diabetes prevalence. And then we have Michaela at CDC, and she speaks to Victor and learns how he's been using these different sources of data to leverage clinical, community, and Medicaid data to better understand food security among people with diabetes. And then she really wants to ensure that all of the awardees leverage this type of data to monitor their programs, and CDC in general really encourages their grantees to track and report individuals with diabetes identified with food insecurity. So that's the basic story, okay? And we have updated the story and the personas based on the feedback, and Gabby has put that link in. So that's just a quick recap. As you can see, our personas and roles. So next slide. So just to share a little bit more, as we did in the first meeting, just to talk a little bit about the persona of Jessica. She's 33, she has a master's in social work, married, living with a spouse, and she works at a community-based organization that is within the county and within the state that we are talking about, and near the FQHC. She likes working with members of the community. What we do want to point out is that the challenge is that, again, she is seeing an increasing number of of individuals with food insecurity and is struggling to sort of keep up with that from a capacity point of view. And the other real challenge is that her community-based organization is really struggling because as they partner with more clinical and other types of providers, they're having to use lots of different platforms, and their own case management system doesn't really integrate and isn't with all of these other platforms. And so that is a challenge, and it becomes an administrative burden and takes away time from patients. And so she really wants to be an advocate for her clients and help them access the services they need, and really wants to find an easier way to sort of respond to the referrals and spend more time with her clients and not have to deal with a lot of different platforms. So that's just a little bit about Jessica. Okay, next slide. So now I want to talk about the feedback that we received. We really appreciate everyone's feedback. And before I get into the specifics, I just want to sort of say the way we approach this is we looked at everyone's feedback. And feedback sort of falls into 4 categories. So one is there were editorial comments that we were able to make. The other is that some of the comments we really ended up incorporating into assumptions. They were more appropriate for assumptions, and we're going to come to the assumptions related to use case 1, which was part 1 of the story, and Sheetha will cover those. So if you don't see in these themes your comments that you submitted, they may be edits that we have made, or they may be in the assumptions. There were some that we felt were better for recommendations, so they may come into recommendations, or we actually revised the story and the personas accordingly. So what we're going to do now is just go over some rolled up themes that came out of the feedback and sort of talk about how we responded to those. But again, if you don't see your specific comments being addressed, please know they could be in the assumptions, in the recommendations, they could be editorial, or we'll come back to them. We also have a couple of comments that we want to discuss a little further with you after I get through the themes. So there was a number of themes around adding additional personas from the CBO, which we did, to patients, staff at food insecurity programs, healthcare academicians, individuals from tribal nations, a whole range. And so what we did is we've added Jessica, as I said, but we really were very confined based on time and resources to not adding a significant number of additional personas specifically for this project. With that said, we do, and I'll come back to how you can do this, we are encouraging all of you to add additional personas for future design and development that will be part of this use case package, but those personas could be used for other related initiatives afterwards. So we want to capture your ideas. We want you to give us the personas and the information related, and I'm going to come back to how best you can do that. So specifically, there were a lot of comments specifically on Kevin's persona. So I just want to call that out and say we revised the personas based on the comments we got, but specifically related to Kevin since he got the most. And they were specifically related to his challenges and goals. And so what we did there is specifically they called out one that, you know, he might not have had, there was a need for an increased need for current resource lists, that his resource list was outdated. And that was a challenge. So we revised the story accordingly and also made it very clear that, the needs of his patients were being documented in the EHR in his federally qualified health center. So those were the major changes that we did with Ken. But again, since he had the most comments, I wanted to call that out. There were also a number of concerns regarding applicability to the story of to how the story is applicable to tribal nations. And so I'm going to turn this over to Kayla now for a moment to comment on that theme.
Thanks, Amy. So we just wanted to acknowledge that we understand the concern about the specific needs of tribal nations being complex and can be an entirely new project. We got that comment. So to at least start having that the conversation at this forum, we will be developing several alternate workflows, which Amy might talk about later. And one will be to address the tribal nation needs, as well as others discussed previously, such as we did identify like perhaps research access to data could be another alternate workflow. So these alternate workflows will help strengthen and demonstrate the generalizability of the use cases being developed. And I also want to mention that at CDC, Dr. Zlipsky, as well as Dr. Wells, they have been working on advancing tribal data elements, standardization, and they actually work on leading the CDC's response to the USCDI version 3 on the tribal affiliation data element. And so we'll be working with them along with other partners to really make sure that tribal is being represented at this work group and that they're participating, but then also to make sure that we're working alongside with them to develop that alternate workflow that I mentioned. So with that, I will hand it over to Dr. Lipsky to see if he wanted to add anything. No, I saw him on the call. He might have dropped off. If not, I'll hand it over to anyone at CDC who wants to add additional information. If not, back to you, Amy.
All right, any other comments on this?
This is Shay at CDC. Just wanted to say thank you for recognizing that. And I think that we may have possible mechanism to collect some of the themes, you know, whether it's the personas and et cetera, for tribal. And I'm going to put in the chat, Georgia Moore is going to be the POC because, you know, as we stand down the EOC, the COVID response, we are moving people over to OTASA who may be able to work on this. So yay, it's not even Friday and we've got some potential solutions.
Great, thank you, Shay. All right, so moving along with other feedback. There were also some themes that the story really doesn't represent the current state. That the electronic collection, documentation, interagency data sharing, it's not really widespread, it's not out there, there's limited data, how much is this happening? So we just want to say that we recognize that this is, you know, not the current state, that it is happening in very small pockets. There are some places that are doing this, but it's not widespread, it's not broad. But we also really want to point out that this initiative, part of the goal of this initiative is to really drive the additional adoption, to really get us to the desired future state of being able to have this information collected and shared and interoperable. So the story is assuming that there is some level of SDOH data sharing that is occurring and data capture. So again, that's more in the assumptions, but I just want to let everyone know, we clearly recognize that, you know, part of the story is more of a future state than current state, and we are acknowledging that, but we all hope we can get to the desired future state. Next slide, please. Okay, so another theme really came back to questions related to the use of the health information exchange as a data intermediary, and whether there's really sufficient SDOH data at the HIE, the extent to which the HIE has that captured in a standardized way and can accept it and can share it, how much data the HIEs can offer, or a data intermediary. And we're using an HIE in this story, but as you'll see when we get to the use case, we actually broaden it a little bit to actually use a different term, a trusted intermediary, I believe. That really could be a community information exchange or other aggregated systems. But the important point here is that, you know, for each community in this story and in general, it would be important for public health professionals to consider like what data assets are in their community that they could leverage if there is already some aggregation going on with this information. And the story is making the assumption that the providers in the HIE have the capability to, again, send and receive standardized data. So we know it's not necessarily current state, but we're making the assumption because it's the future state we're trying to drive to. The next theme is really around, there were questions around the data's representativeness of the population if the data was leveraged from the HIE and from Medicaid. And we have revised the story to more explicitly state that Claudia, who's at the County Health Department, knows that the SDOH data that she is obtaining from the HIE, and we actually already had this in the story for Walter, is not necessarily representative of all persons, but is the best possible data available at the point in time. So again, just calling that out, that we understand that there, are challenges there, but sometimes you got to use the best you have and not let the perfect get in the way of the possible. The next theme is really around clarifying if the SDOH data shared is being de-identified. So we've revised the story to make it clear that the data being shared is encrypted as it's being shared. And we've added an assumption that says that the data really is being shared with the consent of the individual under appropriate consents policies, and that all applicable privacy, federal and state privacy laws or county or others are being adhered to. And in order for the use case to have broad applicability, we did not want to specify whether it was de-identified or identified, because there may be different uses at the state or at the county level. I do want to say we are going to come back to this question to have more conversation about it, but that's what we have done so far. But we do want to discuss this in just a couple of minutes. Next slide, please. So we're winding down on our themes here, but the next theme was really around the fact that the data on interventions are not really being captured by EHRs or HIEs in a sufficient manner. And again, we recognize that EHRs, the ability for them to sort of track and link interventions to support care coordination is a definite known challenge. US Core is currently being updated. And so we're basically also just letting you know that you could consider providing public comment to federal partners on certification requirements that might make this more commonplace if it were required more or implemented more. The next theme is really around suggesting that the state use CDC cooperative agreement funds to encourage greater automation of data and to improve the exchange of information and the interoperability. So again, we feel this is best suited as a recommendation in the final report. I think there is some information that CDC may put in the chat that there are some cooperative agreements that may already be supporting this potential funding, but I'm going to let them weigh in. I'm not quite sure about that. And lastly, there was a theme around suggesting to modify the focus to decrease, modify the focus to be that we focus on decreasing food insecurity in areas where diabetes prevalence is high. And we have revised the story to include that. Next slide. So now I want to come back to a couple of questions and get some additional feedback from all of you. And one of them is what I already addressed. So the first question we have that we'd like a little discussion on, or a lot of discussion for that matter, would be, again, in order for the story to have broad applicability, we did not explicitly state whether the data being shared should be de-identified or identifiable. And so we just want to know what you think. Is that from the perspective of the story, is it okay to just say the data is being encrypted and be silent on that? Or do work group members really feel strongly that we should specify it one way or the other? And okay, Jim?
Yes, ma'am. And I guess it's as much a question as a comment. I'm not sure if I would delineate explicitly whether or not it is to be identified or de-identified. But I think a lot of that gets driven by the use case too, right? So if you're getting specific SDOH data that's related to a food security program, how much you can de-identify that when that's related to a specific health condition for the individual. And while encryption is good, as I mentioned in the chat, the applicable state laws around the information sharing agreements and and in some cases, two-way communication between a PHI covered entity and a non-PHI covered entity have to be factored in there, I think, as part of workflow considerations in some fashion.
Thank you. And I do see your comment here about, the Helios Accelerator call with a similar discussion, and that CDC had participated in that. So yes, I think there are a lot of laws that have to be considered in this. And I think we agree on the use case part, which is why we were leaving it neutral on this. Okay, other thoughts? Or comments? Feel free to put in chat, raise your hand. All right, Laura, you're saying it depends on whether the use case is focused on meeting individual resource needs versus aggregate data for public health purposes. Yeah, so, our use cases are really looking at using this for public health purposes. It's taking individual data, but it's really for that upstream public health use in aggregate. So I think, in that regard, I just want to clarify if you're saying if it is more for public health purposes, are you then suggesting that we limit it, the story to de-identified or not?
I guess, yes, if it is for public health purposes, it could be de-identified, and we could specify that, because then that eliminates a lot of red flags for folks, and it's not necessary to know who those specific clients or patients are.
Okay, thank you for that comment. And we might be able to put a qualifier in there. And, again, we've posted the story in the personas now, but it doesn't mean that, we won't continue to update it based on feedback as we continue to discuss this. All right, any other comments on this? If not, I'm going to move us to the next question, but I don't want to rush the group. All right, hearing no more comments and seeing no more hands. So the second question was, again, based on feedback we got, there was a concern that the domain of food insecurity was sort of too large and too broad, and that aggregating the data may cause like a dilution effect in understanding like where food insecurity exists. Are there similar concerns? Are there ideas on addressing this differently? Just want to throw that out to the group as well. Jim?
A question about food insecurity aggregation. Is that aggregated along certain striations, like type of food insecurity, or food insecurity just in terms of it's just not available, or vegetable availability versus processed foods or something like that? I was wondering if that might make a difference.
Yeah, so we have not really defined that at this point in the use case. So if there are thoughts about that, we welcome your ideas. We're broadly using food insecurity in a very broad way. Thinking about it from the point of view of, access to food, but we haven't really gotten more specific in defining it.
And I can chime in, Amy. So also looking at how the current food insecurity data set as defined by the Gravity Project is across those 4 activities that I shared earlier: screening, observations, diagnosis, and interventions. Interventions has the largest data set. But part of it is, as we look through it, this is a question back to this work group, is that what is the most relevant data, right? If we look across the use cases, there may be an interest of how many individuals were screened, and therefore you would look at the screening data set. You may also want to have data, how many individuals screened for food insecurity, received a referral to a food bank or to some benefits program, right? So, that's when you start combining data sets. So for us is really thinking through of what do you need to look at? But I do want to acknowledge that the data sets are there, the coded terminologies exist. It's really, how you want to define it within the use cases.
Thank you, Evelyn. Okay. Any other comments on this one?
Amy, it's Gabby. I see it
Hi,
coming
this
in
is
the chat.
Murphy here. Oh,
No, go ahead.
Oh, sorry. Yeah, I was just wanted to add a pointer was that in terms of food insecurity, the other angle is also nutrition insecurity. So it depends on how deep we want to dive into in this particular vertical. It's also understanding are they having nutritious food versus just access to food. So I think I'm learning that that's a big difference in terms of perspectives. I think that's just food for thought.
Thank you. Excellent point. Excellent point. Gabby, I know you were about to say something. I do want to just comment. I do see Art's comment going back to the de-identified or identified data, and Art was commenting that the privacy preserving record linkage, could allow for linkage while data not being identified. So that's something that we can also consider. Gabby, was there something else that you want? I think that's what you were going to say. So
That was it. Thank you.
okay, great. So hearing no more comments on 2, or you can come back to it. The third question was really around a suggestion again, that we not just look, the story talks about looking at zip code level information around food insecurity and also around prevalence of diabetes. And so there was a suggestion to focus and leverage census tract data and the social vulnerability index, along with the aggregated SDOH data in the story. So we, again, just wanted any thoughts or feedback on this about whether or how difficult it would be, or whether it would be important to go down to the census tract level and to think about using the SVI.
Hi, this is Lisa. I think the SVI is good data and it's easily accessible. Just have to take into consideration the time frame. It's usually a couple years old. Even though it's at the county level, it may not give you information about current populations within those counties.
Okay, thank you. That's an excellent point to keep in mind. So any other comments on census tract then? All right. Okay. So I think if we go to the next slide. What I did want to do is just again talk about our request of all of you as work group members to feel very free and comfortable to submit persona candidates. And again, the persona candidates, they don't have to be specific to just this story. They'll be part of the use case package, but they could be other kinds of public health professionals, diabetes educators, again, tribal nation leaders or leaders in territories or other, healthcare academicians or researchers. And Gabby will, talk through a little bit on how to do that, but we can include them and then they'll be there for future work. And those personas will already have been developed. So I just want to encourage all of you, because again, we just unfortunately really couldn't accommodate everyone's wonderful ideas on all of the personas, but we really want to be able to add them in to the use case package and have them available for potential future work.
Thank you, Amy. Before I dive a little deeper, I do see a comment from Gia via chat for census tract level. SVI bundles a number of variables, not just food insecurity. Something to keep in mind, as I know, Gia, you have been very instrumental on the input received from your department. If you would like to chime in, we'll love that. If you can, we know that sometimes, this virtual environment, we're not always able to speak live.
I think that there are some variables that exist already that would be more specific to food insecurity that are already accessible. Somebody dropped in there in the chat about the ACS, but I don't think SVI is a good indicator because so many other variables that weigh to create that SVI. So when you're trying to get to specific services that are needed, that SVI might be high because physical activity access is low, or because of other issues not specific to food insecurity. So to just be more specific and get to the level of the measure that we're targeting, we need to find and identify a specific measure that is more comparable, that can be either the proxy.
Great, thank you.
I have a question about their personas.
Yep.
The currently the personas that I've created are for people that actually input or use the data somehow. It's not those that could possibly in the public health realm make decisions on policy changes that could affect public health and social determinants of health policy changes.
Yes, and I think, Lisa, you had sent some comments that we were not able quite to incorporate in everything, if I'm remembering correctly, making the same points.
I sent them till last minute.
No, I wasn't implying that. I'm just saying I was reading them today, so didn't really have time to incorporate in this. But we do appreciate your comments, and again, I would suggest perhaps we did have a conversation again about adding additional personas through this process, and I recognize to some extent that the use of the data more for policy impact and decision making, whether it's through predictive analytics or other things that you might have mentioned, are important. They were not part of this, specifically part of the story that we have today. But it's an excellent point, and I would encourage you to add some personas in, and then we can use them again potentially in the future with additional work, and think about perhaps we'll take another look at any later comments that came in today or after this meeting, and we can continue to revise the story accordingly.
Yeah, and I would just echo that with use case 2 and 3, it might be something that we can incorporate more explicitly or modify when we walk through that. Definitely.
So thank you.
Thank you. And also thank you, Katie, for your comment about the American Community Survey and sort of like the specificity that it offers as it compares to the SVI overall. So we appreciate that. We'll take into consideration. As it relates to the logistics on how to submit a persona, we have created a downloadable link. When you click on this, we'll share it in the chat. And if we have time after we go over use case 1 components, I'll do a little demo, but it is a spreadsheet that uses Victor, the persona that we reviewed in our last call, as an example, and gives you prompts on the type of questions that were used to create the persona. So we're giving you context and an example to support the submission of new personas. We do ask you if you can kindly please rename the worksheet when you send it back with your organization name, entity name, the actor type, so what type of persona that is, and then your name. So I used here my name as an example, and the date that you submit it. This is optional. I want to be very clear there. This is optional. You're not required to submit. If you're really interested in diving a little more into the development, we welcome that. And once you populate those into the worksheet, you can send them back to me. We'll be compiling them in order to consolidate them and put them all into one worksheet. Thank you. And now I believe Sheetal will get us going with use case 1 components.
Okay, great. Thanks, Gabby. And thank you so much, everyone, for the feedback and discussion. So now we'll plan to review the use case 1 components. If we go to the next slide. Okay, so on this slide is the use case package, which will be the output of this work group. And highlighted on this slide in red are those areas that we'll discuss on the call today, which we're referring to as the use case components. And then in subsequent meetings, we'll plan to walk through the same sections, again, as it relates to use case 2 and use case 3. And then if we go on the next slide, please. Before we dive into the components, we just wanted to level set with folks on the line with, with some of these definitions and what do they mean. So just quickly walking through this. So the actors, each actor has a role and performs a set of activities to support the story. And so in a minute, we'll walk through these actors as it relates to use case 1, but they typically include the human actors, which are personas. We have the business actors, which represent the CBO entity. University or the Federally Qualified Health Center. And then we have what we refer to as system actors, which represents like the case management tool or the electronic health record application. And so we'll walk through this more with each of the use cases in the future, but today we'll focus on use case 1. And then the assumptions in the context of this work just really help us identify what do we believe to be true as we are developing the story. And so it could relate to policy, to process. We got some great comments in chat related to this, but what are those things that we collectively want to state up front, which are our assumptions going into the stories. The preconditions are slightly different in that they'll describe, what must be in place from that systems perspective in order to enable interoperable data sharing. And then if we go to the next slide, the transactions specify the data exchange between the systems. The message content will describe the data types and categories of data we hope to be exchanged. And then the post conditions describes the state of the system as a result of what has been exchanged. And lastly, you might have caught this earlier, but we also want to describe alternate flows and the other types of scenarios that could result in the user completing the goal in the context of our use cases. And so our alternate flows will acknowledge that there could be, different information sources and other trusted intermediaries for this data exchange. And to just know that, it's a constantly evolving market. And so we'll want to definitely get your input and feedback and how to address that really well in the use case package. So let's switch over, Gabby, if we can, to the Word document. But before we do that, I'll just pause really quickly and see if there's any questions before we go into this. All right, and feel free again, we'll be monitoring chat, and Amy and Gabby, feel free to let me know if folks have their hand raised or if anything comes in chat, and we can certainly pause through there. So we thought it would be easier to walk through this document here to just obtain your feedback. So again, really looking forward to the collective brain power that we have on this call. We've made some assumptions going into this. We may not be right. We may not have included everything. So really hoping that folks can give us their feedback and thoughts and reflections as we walk through this. So the table that you're seeing right now on the screen is outlining our different actors. So the first column on the left is our human actor. We then have the corresponding business actor, system actor, and then we've also gone in and tried to define their technical role. So if they're an information source and a data sender, they could be the information recipient or a data aggregator. And we really tried to leverage, the work that the Gravity Project has already done. So this might look familiar to some folks on the line, but we're also trying to leverage, other great work that's happening in the field, like for example, with the MenMorph initiative. We tried to define some of these actors based on what other initiatives and groups have already worked through. We don't want to reinvent the wheel if we don't have to. And so for the folks that are participating in these other initiatives, feel free to let us know how we can better leverage the work that's happening in these other spaces and make sure we're aligning it, to the best that we can. And so then if we scroll down a little bit further, we've broken down this first use case into 2 transactions. So the first one, sending the SDOH encounter data in a standard format that will come from the FQHC or the CBO setting. And then the second transaction will focus more on how that trusted intermediary sends aggregated data in that standard format to the information recipient, which in this case is the county health department, and their system actor is that data repository. So now we'll focus we'll take a dive closer into transaction 1 specifically and go through the assumptions, pre and post conditions, and all that good stuff. So feel free to pause or unmute yourself at any time, but I'll just try to run through some of these and walk through this with the team, and feel free to let us know if there's, we didn't miss stuff or we didn't capture it accurately, and definitely looking forward to that feedback. So just quickly walking through the assumptions, we wanted to make sure we stated up front that we know, as Amy alluded to earlier, we're hoping this will drive to a desired future state, but that right now, maybe only some FQHCs and other clinical providers are screening patients for SDOH or social risks or social needs, and they document those question and response pairs and interventions in their EHR. We also wanted to clarify, similarly with our community-based organizations, that they might also be, only some of them might be electronically screening, for example, the screening responses, questions, and their interventions in their technology system. So going in with a lot of assumptions up front, hopefully can get us aligned on what we think might be happening to help enable this story. And we've also kind of explicitly stated here, again, as we're trying to build off of the value sets and work that the Gravity Project has done, we are saying up front that we want these question and response pairs and interventions to be mapped to codes that have been developed through that work of the Gravity Project. We also state, clearly that we want to ensure that the patient's information will be shared and accessed in compliance with the appropriate laws and regulations and policy around privacy, security, and consent. And that in the context of the story in the county where Claudia and others are located, that most of the FQHCs and clinical providers are sending clinical data, and if it's available, the SDOH related data to the regional HIE. And again, we're using these clinical and community providers as well as the regional HIE in the context of this story. But again, we know that this can differ from market to market or jurisdiction to jurisdiction. We also state upfront the regional HIE is only collecting SDOH data from systems that are using standardized coded SDOH data. Again, know this is happening in some pockets of the country, but it's not widespread yet and ubiquitous, and we're hoping that this can drive towards that future state. And then lastly, we have here the information sources. We wanted to acknowledge that they have those appropriate participation agreements to be able to send them, to send and receive the encrypted data to the regional HIE or the trusted intermediary in this case. And if we scroll down just a little bit more, I'll pause here and just see if folks have anything they think we didn't cover in the assumptions, or something, if it's even like, refining or editing or modifying any of the bullets you see here. Pause and see if there's just any initial feedback or reactions. Okay, I'll go fast. Sorry, I apologize. I talk quickly. So if you have anything, feel free to put it in chat or just unmute yourself. The next section we have here is the preconditions. And so again, kind of looking and seeing, what are the, what has to be the state of the systems that are involved in the story, and it could potentially be related to workflow. So first, we wanted to state with the preconditions, we wanted to just explicitly state that the staff at the FQHCs, potentially other clinical providers, and the CBOs do screen for social determinants of health related risks, and they actually document that in their technology systems. We also have stated up here that these systems are actually capable and have the ability to capture and share that standardized individual level SDOH data with other systems. So that capability is already baked into the systems that we're talking about here. And that we wanted to also just state up front that there's an assumption that if it needs to be, the information can be pre-populated with the available patient demographic information, date, and appropriate and unique identifiers that gets captured at the encounter. The clinical providers' technology systems are also able to generate, we wanted to say, standardized diagnoses codes, and can send that information to the regional HIE, and that the regional HIE can also accept both that standardized medical information and SDOH data. So that was some of the preconditions we wanted to outline for the systems that are involved in this first transaction. And I'll pause here to see if there are any comments or questions. And Art, thank you. I see your comment in the chat. A precondition is that all entities have signed governance agreements to enable the sharing of data, whether identified or de-identified. Great. Yes, we can definitely add that. Thank you for that. Other questions or comments? And Art, if you want to add anything to that else, please feel free as well. Okay, great. I'll keep us moving then. And again, feel free to put any thoughts, feedback, questions in the chat, or just unmute yourself. So then we have transaction 1, which is sending the SDOH encounter data in a standard format. And so for this, we have just acknowledged that, okay, the information source is pushing the SDOH data to that trusted intermediary. We've specified in the message content more around the data categories. So we wanted to say that encrypted SDOH coded data identified, gathered at that encounter level could include the screening questions and responses, the diagnoses, the goals and interventions. And again, this really maps again to the code sets and the value sets developed through the Gravity project, so we can leverage that in the message content. And feel free, Gabby, to scroll down just a little bit further. For the post conditions, we want, we just outlined that the trusted intermediary accepts that encrypted data. And then the last part here is that alternate flow. And so, just to state again, and sorry to be repetitive, we know that each community or jurisdiction might have different data assets in the community that might be aggregating and capturing this information. So we do want to make sure that we outline that here. And this is not a holistic list, and we can certainly add, and would love to hear folks' feedback. But we know that this could be data that's captured and aggregated, from healthcare payers, from community information exchanges, from different, vendors out there that are working in this space, care coordination platforms or community-based resource platforms, and other providers' IT systems. We know it's super dependent on what's happening in each of the jurisdictions, regions or markets, and that some of these system actors may play those, dual roles of being an information source as well as that trusted intermediary. And then if we just scroll a little bit further down, simple diagram here, but just shows the transaction of the FQHC and the CBO sending the SDOH data in that standard format to the data aggregator and eventually data sender, our trusted intermediary for, in the context of this story, which is the regional HIE. So I'll pause here and just see if any folks have questions or thoughts or reflections, or just anything that comes to mind as we're walking through this first transaction. Okay, well, let's keep going. And again, please welcome any thoughts or feedback. And raise your virtual hand. That would be great. And so Gabby, let's kind of scroll down. So the next section is we have in the use case package is the table that will then outline all of these components for transaction 2, which now is taking us from the trusted intermediary, which is our regional HIE, to sending this data in an aggregated format to the county health department, which is our information recipient. So we wanted to state, so some of this might look repetitive, but we just wanted to state it again, ensuring that the patient's information is shared in accordance with all the appropriate laws and regulations. We also have that the regional HIEs only collecting SDOH data from systems that are standardizing that SDOH data. We also want to assume, of course, that the information recipient, which is our county health department, has that appropriate participation agreement with their trusted intermediary in place for the purpose of a community health needs assessment, and that the information recipient's data repository is able to process and use this encrypted SDOH, aggregated SDOH data, excuse me. And then with the preconditions, similarly, just building off of these assumptions, is that the regional HIE can accept and send that data it receives from the FQHCs and CBOs, and that the information recipient has a data repository that is able to accept that standardized data. And if we just scroll down a bit further, I'll pause there first and see if there's anything else that we missed or should include.
Hi, this is Lisa.
Yeah.
When you send the HIEs are going to send the data to the public health agencies, is there just sending? There is no way, are you anticipating public health could able to retrieve the data on their own, or is it creating, do we know what type of format this is going to be sent in? It's going to be dashboards that they have access to that can receive the information on these chronic conditions that we're looking at, as opposed to continuously sending information. You just pull up a dashboard, or is it using FHIR that they can just retrieve the information?
Yeah, thank you so much. Great question. So I'll try to respond to that, and then I'll welcome others to chime in. So for this use case package, I think, the way that we were thinking about it is that the SDOH data that's aggregated from the clinical and community-based providers could then be sent the actual data, right? Like line by line data, potentially that's identified or de-identified. And now folks had some good comments on PPRL as well. But we were thinking of sending the data, to the county health department, I believe, but not really in a form of a dashboard. That could be then something the public health department could take that data and develop their own dashboards with. So, and I don't think we had a strong, one way or another, and that's where we would love to get folks' feedback on. Are there, areas that we should think about tightening up the story and make it more clear in the story where it could have broad applicability, but also really give a compelling reason for why public health would want this data. And I think we thought, at least internally in our conversations, was that, like using it for dashboards is an amazing use of it, but would public health benefit from the actual aggregated, line by line data versus just receiving dashboards? And let me know if I interpreted your question accurately and if that helped give us some kind of rationale behind our thinking and how we presented this.
Yeah, that helps. It sounds like we're just going to send the data file, aggregate data. I think we just need to make sure that from a public health perspective, when I've been working with them, oftentimes they don't do a lot with those big data files they get. They often need help sort of putting them in a format that's easily brings them insight, and they can do something which is often a dashboard. And they can log in and get real-time data and not just a big file dump every now and then. So it's just working with public health departments to understand, how they can use that data and what's the best way for them to receive it.
Yeah, that's super helpful. Yeah, and thanks, Evelyn. I definitely think that would be great to add as a post condition too, that potentially needing that support. And yeah, and I know with this work, we don't always specify, the how, but rather the what and what functionality does the system have to support that. And so, but I think adding that in as a post condition would be great. So thank you for that. And then Gia as well, maybe SDOH profiles for their county. Love that. That's also another, I think, potential use that would be certainly helpful. So if folks have those ideas for, what are the uses of the data and the compelling, what would give the compelling reason for public health and how they could leverage that data in meaningful ways. Yeah, love that. Feel free to, keep adding to that. Thank you both. Any other questions or feedback or thoughts? That was super helpful. Okay, I'll keep going. Evelyn, were you going to say something? Sorry, you got mute.
Sorry, yeah, no, sorry, I meant to go back on mute.
Okay. All right, awesome. Okay, well, I'm going to keep us moving here. We just have a few more sections. So the second transaction, again, focuses on sending that aggregated SDOH data. We've outlined at a high level the message content, identifying the different data categories potentially that the county health department could use, but certainly welcome feedback. But again, leveraging the gravity value sets of, screening and question responses, interventions, and diagnoses. The post condition relates to that information recipient being the health department abilities to accept, analyze, and act on that data. And then just restated here, the alternate flows, just acknowledging that each community is different and may have different data assets depending on the work, and that knowing that some of the work is emerging and maybe still in the early design phases, and so want this to hopefully evolve as the market evolves and as communities evolve with the work that they're doing to enable data sharing and SDOH data related interoperability. I'll pause here. Oh yeah, thanks Gabby. And then this is our last transaction diagram, which incorporates transaction 1 on the left, and then as well as transaction 2 on the right, which is again focusing on aggregating the SDOH data, sending that to the county health department, and again, just building off of the Gravity project use cases in this regard. And I will pause here and see if anybody has thoughts or questions related to anything we just presented. And if you'd like to go back to any sections from earlier, don't hesitate to let us know. We can do that as well.
Sheila, this is Evelyn, and just to plug in for the group. As we go through these use cases, I know we emphasized this when we first kicked off. We really think of these as functional and technical requirements for solutions. So as all of you, if you think through, if you are decision makers of what solutions need to be implemented within your agencies or departments, give us feedback. Are these clear enough, right? Is there something else you would be asking for? Or I think that the conversation we just had about, how is the data going to be displayed, visualized, presented back, right? So I think that just keep that in mind as we're going through this. Are we being clear enough on these requirements? Again, as Shita alluded to, we don't say the how, right? This is very unique. These could be implemented in different ways and designed differently, but we want to acknowledge what are those data exchange transactions and what is additional information you may be looking for if you're making a decision to acquire or design a new technology to support this.
Thanks, Evelyn. Yeah, any other thoughts, reactions, or questions? And of course, I know Gabby will go over next steps with the group. So certainly, welcome any comments. And again, just going back to the questions that Amy presented up earlier in the call, always asking ourselves, is this going to meet the needs of public health professionals? Does it provide a compelling reason to leverage the data for public health purposes? And thank you to Gia and Lisa and others. Welcome feedback on what are those potential reasons that make this a compelling use case, and then ensuring it has broad applicability and helping us drive towards a future state. And let us know if anything else is coming to mind too, and you can feel free to chat in or unmute yourself. Certainly welcome that.
I think that, everyone's working on social determinants of health, so it's a compelling story to be able to sort of push everyone in the right direction of capturing this data and sharing the data. I think the other key too is, once we have the data, how are we going to do analytics on this data to understand how can we improve, what is the data telling us, and how do we make improvements upon based on what we're seeing, whether it's at the policy level or at the system level, to improve outcomes of people within their specific communities, which is the ultimate goal. So I'm really not sure when we get to the public health if there's another phase on where the analytics happen and what happens on the public health side.
Yeah, I think that's such a great point. And I'm also trying to think about too in use case 2 or 3, maybe when we also huddle back as a team, we can think through that. But if folks also have suggestions on the line of those intended uses for analytics, we're very open to adding that into the story and making sure that compelling reason to leverage the data is baked in there. So whether it's at, I think, the state level or even the federal level, or something we want to come back and bake into the county level, feel free to let us know if there's certain edits or modifications to the story that we can make, and we'll certainly take that back internally too and see what would be helpful to add to get to that.
The other thing we can do, depending on feedback, is we can always add into the recommendations. If it's not something that's specific to the use case, we have the opportunity in recommendations to talk about more need for data visualization and predictive analytics. So if it doesn't really fit in the use case, we still it's really important information to have in terms of critical uses for public health and ideas on that, because again, we can put those into recommendations about needing to really promote and push that to a more desired state where the data, once it's brought into a public health environment, can really be used and leveraged in that way.
Great. Yeah. And thanks, Jim, for the comment. And then Gia, I also see you had an example on here. Would you mind sharing a little bit more on that?
So just from the use case perspective of the previous comment about states not really having the capacity or time to analyze all this data, that we analyze it and feed it back to them via these profiles. So that not only could they use it for funding decisions, maybe we can use it for funding decisions too, when we write NOFOs and say, hey, you know, show us where your gaps are, and then you can use those same metrics as performance measures moving forward. But it allows the data to be aggregated in one place. A lot of agencies, a lot of divisions are using these same indicators. We all shouldn't be collecting it and analyzing it and making all these different reports. If these profiles for each state at the congressional level or census tract level are already available and updated by profiles annually, then they can go to that data and easily be able to assess it, and it's already analyzed. And we can talk more about what would that look like. You know, is it stratified by gender, by race, by ethnicity, by what? We could take it apart so many different ways, but having one place where it's already, you know, laid out. And in that example, that's only a few metrics in that SBA report, but that's data that SBA is using that they don't collect, census collects it, but they're making sure it's analyzed, and Congress and those districts have that data to make decisions.
That's great. Thanks, Gia. Yes, please go ahead.
Asha. Sorry, this is Asha from CDC. My angle is informatics. I'm coming from a different angle. I mean, this is the first time, or rather, I'm new to the SDOH area. But from what I see, SDOH data is not in isolation. It is part of the clinical encounter that we have. And all that we see, say it's diabetes, we're getting diabetes clinical information so far. We are looking at SDOH as an additional data that we haven't had before. So whenever we do this use case, I want to make sure that it does not appear that it's in isolation, that it is woven into what is already at the EHR, and that we are getting it as part of the rest of the information, but we can look at SDOH, which we haven't done before. So what are the areas, I mean, like the standardization data needs at each point, like where the data provider is, where it gets aggregated, where it goes to county, and how is it getting across to, say, eventually the CDC. So when we write this whole story, I think we should have that cleared up as well, because otherwise it looks like we're only looking at SDOH data. The second comment I had was, this is an informatics heavy thing and everybody is going into it. So one of the actors could be an informatician who can look at, you know, what's going on at each stage and make sure that the standards that are being developed elsewhere and other projects can get leveraged. So those are my 2 cents.
Awesome. Thank you so much, Asha, for that feedback. That's great. And yeah, I think we can go back and look at that. I think that's such a good point about wanting to kind of not create false divisions. If it is, you know, again, like where gravity starts again, and just going back to what Evelyn mentioned, is how that data is being captured in primarily a clinical setting. And then also, yeah, I think I love the idea also of I love all the persona ideas that we've gotten, and I wish we could pick all of them out, but would love for you to add that too, to also the personas worksheet. I think that would be great, given your expertise and background, to you know, see if we can have that persona in there. And then as we go through the use cases, potentially bringing that perspective in. And I don't know, Amy or others, if you have other thoughts, but that's kind of my initial thoughts. I think that's great feedback for us to work on internally.
And this is Evelyn. I'll just chime in. I think I do like that idea, because this ties in, and I see some of my ONC colleagues on. We're doing, and Sheetal, of course you're supporting it, the fit workforce. Like we really, as we're promoting curriculum, and developing a workforce to support public health and health equity, that we really encourage that these public health agencies bring on informaticians, right? And this could very ideally be their role as they're collecting data from different sources, ensuring that they're all aligned and they're using, if they, makes their lives easier, of course, if they're standards based from the initial data capture perspective. But I do think that's a nice way to put it into the workflow and encourage that we do have a workforce that can support this.
Yeah, I love that. Okay, any other thoughts or comments? And great, thank you, Shay, so much. We'll ensure to get Georgia the information as well. Just seeing if there's any other last minute thoughts or comments before we move on. All right, Gabby, I will turn it back to you, I believe. Thank you all so much for the feedback. We really appreciate it.
Wonderful. Okay, I'll make sure I'm not double muted. Yes, so we're now transitioning to next steps. Definitely also an opportunity to go back to anything that needs further clarification or any questions on the members and our participants today. So as a recap, if you were unable to provide feedback during today's call, we're leveraging this time that we have, this convening time, to get your live input so we can, embed it into the development process. If there's any additional input that you would like to share and you believe it was not covered during the call, we welcome you to review the use case 1 components. We'll be sharing them as a post email follow-up with you, and you can send recommendations on revisions or additions to myself by Wednesday, June 8th. Given our cadence of bi-weekly meetings, ideally we want to get that a week before so we have wiggle room to review it and really give it that attention that it needs, and incorporate it into our next work group call, which will be on June 15. And now I'm going to kind of walk through a little bit about how to submit persona candidates. Again, this is an optional homework assignment. There's no due date until the live course of our work group, which is July 27. But definitely encourage you all to submit those personas and formalities. I heard, we're gonna reach out for the representative of tribal. So bear with me here. We're gonna do a bit of a demo. So when you go into this link, it's gonna open up a Excel file. You can download it or right here on the arrow. And then from there, the entire the worksheet will open up. So it is very small here, but as mentioned, we do provide an overview here of what is a persona, right? What is it that we're referring to when we talk about persona? We use Victor, our current persona, who is a public health program director. We have the categories of age, education, family status, employment, information about the persona and their preferences, challenges, and goals. So these are some of the prompting questions to support you as you build out. You definitely do not need to send back Victor. You can insert there your new persona and you will just save it as noted on the renaming convention so it can help us track and ensure that we consolidate them into the use case report that we'll be sharing with all as our final deliverable for this work group. So that is a bit of a demo. I'll pause there and see if there are any questions on the personas worksheet. Pretty straightforward. And I gotta say, really thank you all for the due diligence. Everyone that submitted comments on the personas and story via track changes and comments on the work document was extremely helpful to help us go through them. So we really do appreciate the time and effort spent on the review. And we appreciate, those additional personas as mentioned. Thank you, Shay. I do see your comment. No problem. And as friendly reminder, our work group meeting materials, recordings, slide deck, and additional documents reviewed through these sessions will be posted via Confluence. If you have not joined our work group, we currently invite you to sign up as a committed member. And as a recap, a committed member is an individual that has voting rights. When we do consensus voting, this work group votes on the project charter states that this work group has power to vote on 2 deliverables. We completed one of them, the business case. The next deliverable to vote on is the use case package that will be encompassing of all use cases 1 through 3, and that will happen at the end of the work group, so on July 27. And the other option is other interested party. The difference there is that your vote does not count towards consensus. You are welcome to provide input, comments, talk to us live through this work group calls, but just the voting part is what's not there inclusive of. And if you have any questions, any information, Confluence does not work for you, or there's any technical issues, myself, Savannah, and Kyla are here to support you all. And since we do have a little bit of time, I will go ahead and pause here for any comments, questions before we let you go, maybe 5 minutes before.
I just wanted to say thank you, Lolita, for sharing the Healthy People 2030 goal for food insecurity in children. So thank you for sharing that as well.
Perfect. Thank you. All right, and all of you being part of this call are being supporting the consensus building process that will make this use case package unique and really groundbreaking because we are doing a cross-sector review and development process to really support the efforts of the National Center for Chronic Disease Prevention and Health Promotion, who are the sponsors of the work group. And as mentioned in the chat, I'll put in the link in the chat. If you are new, all of our materials of the work group will be on the URL that I just posted via the chat. We have the finalized public health business case available now. If you reach consensus, you can click here and you have access to it. Our work group meeting agendas and materials are listed here. So for today, as you can see here, our agenda as well as our homework. So if you don't mind, please provide additional feedback on use case 1 components via email by June 8th. And as optional, you're able to download the use case persona worksheet. You can rename it by using this example here, and you can populate as many personas as you wish to provide to us, and you can email those to me. The updated persona and story that was reviewed today, Amy and the team, it's available here. So the revisions have been highlighted in yellow. So that's just for awareness. We want to ensure, and as a team had mentioned, we will continue to tweak them as we hear from all of you. And our upcoming meetings, as mentioned, June 15, and then the remaining ones are here. Any questions? Wonderful. I do see our CDC colleagues. Not sure if you have any closing remarks, but without further ado, this will conclude our meeting.
Thank you. Bye.
Thanks, everyone.
Thank you all. Take care.
Thanks, everyone.